So we are going to have an overlook of the comprehensive approach and assess what are the risk factors. That is what the question is. How do you assess and stratify the risks? It's described in literature, it is multifactorial. Genetics is the most common cause and is the least common cause actually, I'm sorry, is one of the cause, contributes only 10% of the etiology. And I'm sure everyone gets asked that, is the parents responsible for the myopia in the child? It is polygenic in nature. There are multiple genes which are involved. We cannot start doing genetic tests for all. However, for Dr. Ramesh mentioned, if you put your clinician scientist cap on, and for research purposes, you may want to do genetic tests in certain kinds of progressive myopias. Near work is the most common reason. We looked at peripheral refraction. I don't need to go into the depths of it. And the light exposure means the screen time. Excessive screen time is always the most troublesome factor. So here there's a combination of near work and the light exposure from the screen is the one which is the most commonly responsible factor, environmental factor for progression in myopia. Why are we talking about it? Like I said, that it's no longer just giving a 2.5 glasses to any child. There are so many risks associated with it. As you reach -6 diopters by the age of 10 to 15 years, you expect them to have these changes in their future. So we are looking at more futuristic perspective, and whenever we look at the child, we try to think about what is going to happen 20 years, 30 years down the line. So right now the child is doing quite well. So that's why there's so much discussion about myopia. So what's a comprehensive approach? A very, very detailed history, good documentation, stratify the risks, very thorough ocular and systemic examination, define pre-myopia and progressive myopia, take the parents into your discussion, and then have treatment strategies. What does a comprehensive history include? Of course, we asked about the age and gender. That is also one of the factors. Earlier the child presents, more risk of progression. Later the child presents post-pubertal, the risk is slightly lesser. If there is a history of prematurity, low birth weight, again, these are behave a little different as compared to, and that's why the debate where atropine can be used in such children or not, that debate is still ongoing. Parental history, like I said, 10% of the cases are related to the family history of having siblings or parents having myopia. Ocular complaints like frequent eye rubbing, excessive near work may contribute to other types of progression. One common reason is keratoconus, which causes a change in the corneal curvature, which is responsible for myopia. So atropine again won't work because it's not an axial myopia. Onset of myopia, glasses compliance, outdoor activity, the routine questions which all of us know, but we may not actively write it. It's very important that we document in all. How do you stratify the risks? Similar to the points what we saw in the history. So before the child gets examined, your history, your past history, your personal history, as well as the family history itself tells you, okay, this child may be, it's not a model, but it tells you it's maybe, and we have to treat them differently, or we may have to treat them very carefully and have follow-ups much earlier. How do you document? So this is something what we do at our place. We document in a report card format. So we have the parents telling them out what is your myopia progression of your child. We draw these curves saying that this is the axial length. And if you see there is an axial length here against the refractive error of the child here, and then there are the number of visits. So that's very easy for them to understand. For -1 becomes -1.5. The parents may not much matter because the child hardly complains, but this curve actually tells them, okay, this is like a report card for the parents. So it's a little concerning and they take things more seriously. Ocular examination, what is different? All children up to the age of 12 years at least, or even those with progressive myopias up to the age of 16 years, a cycloplegic refraction is must. Your diagnosis will be based on cycloplegic refraction only. We had a lot of discussion on peripheral refraction. I will not go into details of that. Again, very thoroughly what examination means is look at the accommodation lag or lead. Its role is similar to peripheral refraction. It's similar to what treatment strategies you want to adopt. Again, there's a separate discussion, but this is something which you want to keep in mind as, again, it was mentioned by our chairperson that sometimes there is small esophoria and you would have a lag or leak of accommodation. A very good dynamic retinoscopy, or if you have a very good optometrist or yourself are very good in retinoscopy, this is something which needs to be seen. What do we mean by thorough ocular examination? We do a very good slit lamp examination for all children. Is it really special? This child came with -10 diopters here. Look at the arm span, much longer. Look at the facial features. Look at the hyperextensibility of the joint. And doing a dilated fundus examination as well as slit lamp examination is must. And what we see here is a small equatorial cataract. So this child had some symptoms which are similar to Stickler's syndrome. So it's very essential that you look them very carefully. Now again, why it's so important? One is diagnosis, the other is whether our routine treatment strategies will work in them. So it's not that if the child presented to you at the age of 10 years with -10 diopter sphere, does not necessarily mean you start with atropine, because this is a complete different spectrum we are looking at. It may not be axial progressive myopia. Investigation do you do differently? A scan is must in all children when you are managing, irrespective of whether a myopes or hyperops. It's very essential that your refractive error, what you find out, should correlate to your A scan findings. Topography is good to do, not must. And in certain situations where there are allergic conjunctivitis associated or keratoconus and ocular surface tests like non-invasive T-BUD may be useful, and OCT for choroidal thickness is what we discussed in the beginning of the class. So a question being asked always, what do you define who is progressive myopia? Where do you start treating? Anyone who is progressing at the rate of 0.5 diopter sphere per year or more, or a correlating axial length of more than 0.2 millimeters per year are defined as progressive myopes. Then there is a definition of pre-myopes. We'll not go into the details of that. So 3 things, RAK is what we must remember: refraction, axial length, keratometry. All visits, all children, whether they are progressive myopes or not, it will be very useful in progressive myopia. This RAK is supposed to be done for all the children. Topography, OCT, good to do. Again, for research purpose, yes, it may be a biomarker in future, it may be a clinical marker in future, but it is always good to do in some of the children. What is our myopia control army? We saw over the wide spectrum in the previous talks, which has covered everything. Certain important points which I want to convey through this: full correction, there is no role of undercorrection. Any myopia should not be undercorrected even by 0.5 diopter, because undercorrection means you are giving a progressive addition. It causes a peripheral defocus that itself can cause a progressive myopia. Multifocal contact lenses, only a contact lens itself does not have, a single vision contact lens does not have any role in correcting progressive myopia. Orthokeratology, effective, temporary, difficult, of course, and there are some group of people who really love doing orthokeratology. It gives quite immediate results, but once you discontinue it, the risk of progression continues. We just saw the debate about atropine, highly effective, percentages vary, we have for and against, so be cautious while prescribing atropine. And there are new treatment modalities coming, which is red violet and light therapy under trials. What does the World Society for Myopia Control consensus say? Dr. Rohit mentioned very clearly, lifestyle modification is a must. So that emphasis, environmental factors like we saw in the first slide, is very, very influential on the children's myopia progression. That comes first. Low dose atropine and ortho-K, as well as the multifocal contact lens, comes the second. What doesn't work is more important than what works. Undercorrection doesn't work. Progressive bifocal in otherwise a child, otherwise normal, does not have strabismus, doesn't work. Blue light blocking glasses, I'm sure everyone has those questions whether Blu-ray glasses work for children with progressive myopia, or rigid gas permeable lens does not work for myopia. Next generation spectacles, in-depth discussion we had, and this was the beautiful table which is already mentioned by Dr. Rohit. Overall efficacy so far has been described as 57 to 79%. Suitably, what I understood that it is more appropriate for children more than 8 years or more, but I would like to have further discussion on this if younger children are more suitable for such kind of glasses. So to summarize, a quick table which may make things easier to decide. History, we focused very clearly on history and documentation. Cycloplegic refraction is must, there is no further discussion on it. You classify where does the child stand, a hyperop, premyope, myope. These common things will remain about the history. Educational, outdoor activities more than 2 hours. Now, how do you frequently you call them is the next question which most of the audience have, and do you call them depending on what you find in the first visit? You find them pre-myopes, you call them little early. You find them hyper appropriate for age, you can call them after a year. You find them myope with high risk factors, you call them little early in 3 months, and look whether, do a comprehensive examination whether they are more at risk, because at-risk stratification cannot be done at one visit itself. You need more visits to do at-risk stratification. Now let's say someone is a progressor, what do you do with that? Of course, atropine low dose is always the option. We just had a debate on it. What are the other options? What are next generation spectacles, multifocal contact lens, ortho-K? Everything depends on the discussion with the parents as well as the risk stratification of the child. Whether the child is stable, you must continue atropine for one minimum of 12 to 24 months, and then only discontinue only after 2 serial visits you have of no progression noted. Again, risk stratification is important. For those who are progressing in spite of all your efforts, it is essential that you use monotherapy with addition to something else. So more than atropine is something beyond it is required. To summarize quickly, identify at-risk children, monitor the RAK, refraction, axial and keratometry. Discuss with parents, establish goals for future. Cycloplegic refraction is essential, undercorrected myopia is unacceptable. Go with monotherapy first always, as one size does not fit all. Thank you so much for patient listening.
Thank you, Jenil, for that wonderful summary. Any questions? I just wanted to say one thing. If the age in years and the myopia is more than the age in years, like 1-year-old child, if the myopia is -1 or 2-year-old -2 or -3 like that, then you are thinking about something syndromic. This is something I think my friend Dr. Ken Nischal always talks about. Myopia more than the age, you need to think about non-axial first and then the axial. Even if somebody comes at 4 years, because most of the children are born hypermetropic. If they are -1 to begin, we have to think something different. Any questions?
Any quick questions to take?
Yes, Kunjal?
Can we have the mic quickly here, please?
Orthokeratology is not very much popular in Mumbai, and I try and motivate a lot of patients for it, but not many really land up with a trained person. So what are the exact cases in which you would refer them for orthokeratology, and until what age is it worth trying orthokeratology?
Yeah, very briefly to answer. One, as combination therapy, it's good. If something is not working, I would not start personally orthokeratology as the first one. Second thing is more than 8 years or 10 years, if they can wear it, that could be as one of the primary. Because if you see there also there is a limitation. If they have more astigmatism, orthokeratology becomes difficult. It's a pure spherical where your dim glasses cannot be used more than -10. Then probably orthokeratology as a primary modality. I would say in one word, older children, it could be a primary modality as well.
In whom cosmesis is a major issue. So that's why it lands up coming in those early teen years when wearing spectacles of any form is a major challenge. So they are the only ones who will also be willing to accept that spectacle free. So they are looking for a spectacle free day. Only those would accept also ortho K.
Okay. Thank you everyone for this wonderful session. Thank you, the chairperson.